Delighted today to have Mary Catherine Beach be our BI seminar series speaker. And so I will let Mary Catherine introduce her title for this talk, but I get the joy of introducing Mary Catherine, who many of you may know, but still always nice to get to sing the praises of our people in here. So Mary Catherine Beach is a professor of medicine at the Johns Hopkins University School of Medicine. She holds a joint appointment in the Department of Health, Behavior, and Society at the Johns Hopkins Bloomberg School of Public Health. She is a former Greenwell postdoctoral fellow and was a health policy fellow in the office of Senator Hillary Rodham Clinton. The fun thing about doing these intros is you learn all of these things about your colleagues you didn't know. She was a recipient of the RWJF Foundation Generalist Physician Faculty Scholar Award. And her scholarship about respect and relationships in healthcare encompasses both the empirical and the conceptual dimensions. Her empirical work is focused primarily on respect and communication between patients and clinicians. And for the past several years, most of her research is centered on people living with HIV and sickle cell disease. So her empirical work has been funded by NIH, ARC, RWJF, and Greenwell. So please join me in welcoming Dr. Beach.
Yeah. All right. Thank you. Can you guys hear me? Is the mic picking? Oh, okay. Doesn't feel like it's me. All right. It's wonderful to actually talk to you guys when I see so many of you and I don't actually know, sometimes we don't catch up on what each other are doing. So I'm really excited to get any feedback you have on this work. It is just me presenting, but because I do so much of my work with Sam Saha, and we've created so many of these slides, it's unclear who's created which slide. I'm giving him credit right out on the title slide. I have no disclosures relevant to this work or really at all. So first I'm going to start by describing what stigmatizing language is when I'm referring to it, because it's in the title of the talk. What I mean by stigmatizing language is words, phrases, sentiments, or descriptions that may portray the patient negatively that would lead a reader to form a negative impression of the patient. And we focus what we call stigmatizing language on the impact of the reader rather than the intent of the writer. So we don't have to adjudicate what somebody intended when they wrote something. We're just trying to focus on if somebody read those words, could they form a negative impression of that person? Now, this initial, okay, the slides aren't advancing. Oh, yep. Yeah, they are. Okay. The initial discovery of stigmatizing language actually occurred, I want to say, in 2007 when Carlton Haywood and I were working on a study looking at how clinicians' attitudes towards people with sickle cell disease impacted their pain management quality. And so what we were doing was we were trying to go into medical records and look for indicators of pain management quality. And because there was no existing measure, we were looking at hospital guidelines and then trying to figure out whether the clinicians were prescribing the appropriate amount of medication based on the patient's level of pain. And what we realized is that there were so many times where the clinician would write that somebody's pain level was like a 10, but then there would be all of these words around it that would suggest that the pain they actually didn't believe that the pain was a 10. So they would do things like put some objective measure, insist or chatting on the phone, this supposedly objective thing that would discredit the patient. They would put some of these words in quotes and make the patient look like they were being difficult. And they would put things into the note that would sort of blame the patient for not following the advice, as if that was a reason why they were still having trouble. So those were we had these three categories of the sentiment that was being conveyed in these notes. And we never actually wrote that up as a paper, but what we decided to do instead was see, okay, if this language appears in a clinical note, what happens to the person who reads that note in terms of how they feel about the patient? So the first study that we did on this topic was a study that looks at the impact of stigmatizing language in these records. So this was basically looking at the transmission of bias. And what we did was we had a randomized study where we used different versions of the same note for a hypothetical patient with sickle cell disease. So we basically took language that you can see on the stigmatizing version um, that is that we found in actual notes. So that is really what is written in notes. And then we tried to rewrite it in a neutral way. And so we had these two versions, the stigmatizing version and the neutral version. And then what we did was we asked people how they felt about this hypothetical patient using an attitudinal scale that we had developed in a previous project. And we asked people how much pain medication they would give the patient using a multiple choice question. So, I mean, really not surprisingly, if the person got the stigmatizing version, they reported more negative attitudes towards the patient, the hypothetical patient, than if they got the neutral version of the survey. And then also, okay, sorry, that I should fix that. That title is wrong. This is pain management. So they also gave lower doses of pain medication. So in multiple choice questions, they would choose sort of like a less aggressive option over several multiple choice questions. So when we published that study, I got a request to do an interview for Slate magazine. And Danielle Offrey wrote this article about it called Your Medical Chart Might Be Biased. And in that article, and when we were having our conversation, what she called it was she said that our supposedly objective medical records contain racially laden dog whistles. And I thought that that was insightful for a couple of reasons. One is that because the work that I had done had been in sickle cell disease, I had not been thinking about this. And 99% of our patients with sickle cell disease are of African descent. I had not been explicitly thinking about this as like I know that there was a lot of bias against sickle cell disease for a lot of reasons, race being one of them, but I'd not been really thinking of it as like, is there bias in this language in outside of sickle cell disease? And our conversation sort of prompted me to think about that. And then the other piece of this was this idea of dog whistling, which is like, it's really only the dog that can hear it. I felt like a lot of the language that we would put in there that would stigmatize patients was you kind of had to know like that you were sending this subtext to the other clinicians who were reading it. Like you made it look like you were saying something objective, like you're quoting someone. And so it kind of looks like you're being objective, but anyone who is inside knows that you're actually saying something else. So the next thing we did in response to this was we started thinking about, I actually presented this work and Vicky Eintwistle in Aberdeen, Scotland, came up to me afterwards and she said, have you like looked at this book, Epistemic Injustice, which I know now everybody talks about, but I hadn't at that point. And she talked about how a lot of the language I was describing was a manifestation of testimonial injustice. So where a speaker receives an unfair deficit of credibility due to a prejudice on the hearer's part. And so I picked up this book and I read it and I really found that it was life-changing. And then I started to see this language in so many other places. And I started to notice that even like in the New York Times, people were reporting, articles about medical gaslighting, like when something's wrong, but like no one will believe you in healthcare. So it kind of felt like it was a larger problem that people were starting to notice. And then there was an article in the Chicago Tribune where the quote was from Xavier Ramey, 9 times out of 10, I was completely brushed off. If there was ever a book on medical racism, it should probably just be called They Don't Believe Us. Now, for those of you who've known me a long time, I have had an interest in what it means to respect another person for a long time. And one of the things one of the projects I've been engaged in over the years has been doing focus groups about what respect means to people. And we published a paper called Diverse Patient Perspectives on Respect. And in that paper, I noted that like we did qualitative analysis of focus groups. And the focus groups were done in the early 2000s to look at racial disparities in healthcare. And so they were focus groups that were like uniform by race and gender. And what I noticed is in the focus groups where there were African American men and women, like a lot of the dominant dialogue about what respect means was about you know your own body and how like you can't tell me there's nothing wrong. Like that's disrespect. You know, it's like you know what's wrong with you. And that really didn't come up with the other groups. Now, I've talked to plenty of people who are not African American who absolutely think this is true. It's just that it didn't organically arise in the other focus groups. So then I started thinking, okay, this is showing up in focus groups. This is what respect means. You only really know what respect means when you've experienced something that will like tell you. A lot of times you take things for granted unless you've experienced it. So I thought this was really important that this is what people are saying. And then if you look at language and health records, you can see that there's ways in which disbelieving people does appear in the words that we choose. So I partnered with a linguist who I'm not really intending you to read this big paragraph, just to say that linguistics is incredibly interesting and also like complicated, and there's a lot that goes into it. But basically what epistemic modality is how we use language to encode whether something's likely to be true. So there's a bunch of different ways we can do that. And we decided to pick 3 ways to look at linguistic epistemic modality in medical records and look at whether those things differ by race and gender. And so we looked at about 8,000 notes written by 164 clinicians in an internal medicine ambulatory practice, about 1,890 unique patients. Now, I'm just going to show you results of 2 of the things. The other one was consistent as well, but it's more complicated, and we could talk about it later if you want. But we looked for quotes because one of the main ways we saw people's words getting doubted was to put them in quotes, like scare quotes. And then we looked for judgment words like he insists, he claims, apparently this happened or whatever. And we looked, and the odds of any of these things happening in the notes written about Black patients compared to white patients was significantly higher. For women's words were significantly more likely to be put in quotes, but the other judgment words, et cetera, did not differ by gender. So this was a very early attempt to look at these features in medical notes. We later, and just most recently, looked at a more sophisticated models using natural language processing. So we had 2 major categories. So we have this undermining credibility category, which is what we tried to look at in that first paper. But we also had a category called supporting credibility in terms of supporting someone's competence to tell you something. And believe it or not, and it does seem weird to a lot of people outside of medicine, but often enough in someone's note, we will write down whether someone is a good or a poor historian using one word like good, like it could be reliable, unreliable. There's a lot of ways of saying it. So if the word historian picks up, unless it's a note written about a historian and their occupation is in there, it is like almost always referring to them as either good or bad in terms of their ability to tell the story. And what that is like an undermining or supporting of someone's competence to tell you the story. So in testimonial injustice, you can undermine competence or you can undermine sincerity, where you think somebody might be like lying. And so we had words and we split them up, tried to split them conceptually into those categories and look at differences by race in the use of those words. So this is a lot, and I'm gonna walk you through it. But basically, we looked at 13 million notes across our health system in 4 departments, internal medicine, emergency medicine, surgery, and OBGYN. And what we found was it was consistent with the hypothesis that this undermining language occurred more often in the notes of Black patients. So a higher odds of it appearing in the notes of Black patients, both in terms of competence and sincerity. And then a lower odds of that language appearing in the notes of Black patients supporting credibility. So very consistent findings. You might notice if you're looking at this table carefully that there's actually the opposite finding for notes written about Asian patients where there's less language undermining credibility and more language supporting credibility. And I don't really have an explanation for that. We could talk about it. Okay. So all of that is like stigmatizing language in terms of credibility. There has been a bunch of work on stigmatizing language more broadly. So I'm going to talk about that. Shortly after the testimonial injustice paper came out, this paper came out that has gotten a lot of attention. This was negative patient descriptors, and it was documenting racial bias in the record. And what they did was they looked for a list of 15 words. Those are the words up there. The 3 words that are bolded were the most common words, so non-adherent, non-compliant, and refuse. So they all have to do with like accepting or following medical recommendations. And the rest of the words kind of deal with somebody describing someone being sort of difficult to interact with. That all those words were put together. And so what this paper found was that there were more words, a higher odds of words appearing in the notes of non-Hispanic, Black, and Hispanic or Latino patients compared to the notes of white patients in this academic center in Chicago. So that got a lot of attention. And the one thing that I was still like a little uncertain about after this paper was like, what if those words, and I knew from our own work that like words like, combative or exaggerate or hysterical don't appear in notes very often. So I was kind of wondering, like, can we tease apart what sentiment it is that is getting conveyed in these notes more commonly? So what we did was we, with a team of people from the Whiting School of Engineering, we took 25 terms. Some of them were the same terms that were in that paper, and then there had been another paper published that was sort of similar. So we looked at all those terms and we kind of came up with the different categories. I've already talked to you about the credibility category. This is where that data came from. But we looked at what we were calling demeanor. So somebody's, difficult to interact with, and there's a bunch of words there. We looked at words around what we're calling conformity, which is not accepting or following advice. And then we threw in this appearance category where someone might be described as poorly groomed or disheveled. Now, for any clinician in the room right now, I just want to make a few caveats. So a lot of the terms that we identify as stigmatizing are commonly used in clinical communication, and they could reflect the culture of medicine rather so than a bias towards a specific person. A lot of times we get pushback because it's like, well, people they are refusing a flu vaccine, or they are, actually combative, and that's clinically important to know. I understand. These could accurately describe people's behaviors. They could be defensibly used, and they're not necessarily words that should never be in a record, but they probably could be avoided in most cases to reduce stigma. So we developed these NLP models and we released them. We did them on Hopkins notes, and then we had to kind of redo them on a publicly available set of notes, which is the mimic set of notes. So we were able to release the models that were done on those. And so those are out there in the world. And just to give you a sense of what we found in addition to the credibility finding that I showed you, if we look at the prevalence of these terms in notes, credibility language, this like doubt or poor historian stuff appears in less than 0.5% of notes. Demeanor, describing someone as difficult, still less than 1% of notes. Describing like someone's, as non-compliant or refusing something is a little less than 5% of notes, but it's the most common category. And then, really very few notes describe people as disheveled, et cetera. But all in all any kind of stigma appears in about 5.5% of notes. And if you look at differences by race, in the blue bars are Black patients, the white bars are notes written about white patients. The green bars. So then you can see that there are differences, statistically significant differences across all the categories. And we've written about the credibility. We probably will publish the paper that shows a fully adjusted model on the other categories, but it's complicated. And we also have looked at positive language. So now we're kind of incorporating that in. The other thing to say about this paper is that right around the time we published it, ChatGPT was released, and then everything became much more doable, and these kind of became a little outdated. In addition to the outdatedness of these models, the problem with centering the efforts to identify and reduce stigmatizing language on single words is that most stigmatizing language doesn't occur as a single word. So EPIC, I gave a seminar on this topic, I want to say 3 or 4 years ago, and there was someone from EPIC there. And it was amazing because we were able to then have a partnership with their health equity group. And then we were partnering with some of their other work groups because they're very interested in reducing stigmatizing language. So the initial tool was this idea where you could click on something would squiggle as if it was misspelled. We weren't really sure clinicians would like this. And then you could drop down and you could destigmatize and it would suggest a replacement. The thing is it's not really easy to replace a lot of these words. There was no NLP built into this, so you can't have words squiggled that are not being used in a stigmatizing way at all. It was just we were kind of worried that this wasn't gonna work, but this was one of their earlier efforts and we were kind of advising them about this. But as I said, I think most of the words are not, most of the stigmatizing language is not word-based. I think basically what it is that clinicians get frustrated and it's anytime you choose, anything you say, if you're irritated, comes out irritated. And it just does because you pick words that reflect that. You phrase things in ways that reflect that. So a lot of the stigmatizing language, when we sort of published a more qualitative analysis, was fell into different categories, like describing someone as difficult or unpleasant. You really could do a great job of that, a great job without using any of those words. So, then there's the stereotyping. If you quote people, you quote poor grammar, you quote African-American vernacular English, you are painting a picture of someone. It's unclear why you've chosen to quote those words, but it's really probably unlikely to be helpful. Even though I know we could probably get a question about quotes from the clinicians, we can talk about quotes. I know it's complicated. And then there's disapproval. You can just highlight that people are making poor decisions, and you can undermine their credibility without using any of those words that we had in our models. So I think there's just a lot that can be done when that is stigmatizing to people if you just write free text. I don't think the solution is to template all notes, but I do think that free text really does open up a lot of different ways that you can stigmatize people. And so I don't think it's going to be so easy to get rid of that. This is just a model, we did a whole further qualitative analysis beyond what I just showed you that's not published yet, but this is the figure of we did a sentiment map of how, the blue bubbles are the big categories of the main message that gets conveyed by stigmatizing text. Whereas the green bubbles are sort of like other ways that are sort of subcategories of different things. And you can have a quote that just kind of manages to hit three of these bubbles all at the same time because there's so much detail there, and it can really make people look like they're being unreasonable or untruthful or stubborn pretty easily. And as an example of that, we did an analysis of notes where patients sign out against medical advice, and there is a ton of stigmatizing language in those notes. Sometimes it's because there's a conflict, and I'll show you in a minute what I mean by that. There's a lot of detail that gets conveyed in that conflict. I think also clinicians are maybe trying to protect themselves from legal action or malpractice. They want to make sure that they've made it seem like they're being very reasonable and the patient's being unreasonable. If you look at some of the things, the details, like these aren't even really actually the most dramatic, like they're cinematic. Like when we have very little time to write notes, and yet we find ourselves with paragraphs describing people's behavior and all the things that they said. And I think it's probably over the top, probably doesn't need to be there for malpractice reasons. And I think, again, it does reflect people being pretty frustrated. So, all right, so now I'm going to pivot and talk about what I think are solutions to this, potential solutions. So first, I think that we haven't really been aware of this for a long time. Like, I think we got away with writing whatever we wanted, even before open notes. I mean, I don't think open notes was really changed it that much. I think that when I talk to clinicians, I think a lot of times people will, especially if we're like, I'm not really trying to be confrontational about it. It's just, it's like, hey, look at this and look at the impact that it could have. And people are like, oh, yeah, like they really realize it. And so we've had, there's been a national movement. There's tons of papers now coming out. I get an invitation to review a paper on stigmatizing language like every week. And I review a lot of them, and it's really interesting. I mean, people are paying attention. So I think that raising awareness of this and making it sort of socially unacceptable to write in this way is going to actually have a difference. This Center for Healthcare Strategies collaborated with us to make a toolkit for reducing stigmatizing language. I don't think it's super great, but it's not bad. Also, so some of you guys remember uh, uh, our students who, Aaliyah and Ezra, who have gone on to Columbia and Harvard, who have both in their first year of medical school texted me and said, oh my gosh, we're reading a paper, like this paper, and it's been one of the ones I showed you on stigmatizing language. So like, and we teach it at Hopkins, it's in the first week of medical school. So I think we are going to be addressing it in medical school curricula, and I think that will, hopefully affect some change. And then I think we are working with Epic, and also Abridge. Abridge is the ambient AI company that we should talk about how that will change notes, but I'm not officially going to talk about it, but it could be in our discussion. Abridge, if any of you know, like there is, you turn your phone on, it records the visit and it writes the note for you as a clinician. And so like, let's think about how that will change things. I suspect there will be a lot less of that frustration that shows up in the note, but if it could still have bias in the way that, any AI program that relies on humans could have bias. And I don't know yet what that's going to look like. The other thing we've done is to take on this issue of quoting patients, because like so much of the stigmatizing language was centered on quotes. We published this paper on in Annals of Internal Medicine. We start off with this, the quote from About Quotes, which is called "The scare quote is the perfect device for making an insinuation without proving it or even necessarily making it clear what you're insinuating." And I thought that was so such a great insight, because we would look at these quotes in notes and we would be like, wait, I don't know. I'm feeling like the doctor thinks this is ridiculous, but I can't tell, or maybe they just don't believe it. Like, I don't know, but why is this in quotes? Like, why these words? Um, and not to go through too much of this, but basically we, in this paper, went through like, when do we think it's worth quoting? So there are times where we say it's beneficial to quote, like basically the exercise you should go through before you're writing a quote about a patient is it really important that the reader know that they said exactly these things? Is that really important? And so if someone says, I have chest pain, it feels like an elephant sitting on my chest, that's like a clinically meaningful thing for somebody to say, put it in. I think you could put in other things that aren't like physical symptoms, but like maybe it has to do with their values, or you really want to convey the intent that this person had. I'm willing to believe there's lots of times where it's worthwhile. I think, there's plenty of times where it's harmful. I think you can see what I'm talking about. Like, no one needs to know that the patient said that. I think that, reporting, like putting things in quotes that are, still a 10 is probably harmful, because it sort of makes it seem like you might be doubting them. And then there's tons of quotes that exist in records that I have no idea why they're there. Has been off cigarettes for a year, in quotes. Why? Like, would just say a year, like it doesn't really add anything. Her living situation is, quote, not ideal. Like, what are we saying with that? Like, just take it out. So I think that is gonna help. So the other thing we're doing that's more solution focused, if we think about what it means broadly to respect people, is we're not just trying to reduce stigmatizing language. We have come to see through this work that there's actually things we can do in records proactively that would humanize people, and I think could make a difference in improving care. So if stigmatizing language can lead to more negative care, poorer care, more negative attitudes. I think that humanizing language, where you can really view someone as a person, their strengths, what they think about things, what they care about, who cares about them. I think there's ways we can use language to make care better. And that's what I'm really excited about now, because I think we're not paying attention to that. And this is a perfect opportunity and a time. And so to give you some context for what I mean, there's this model of dehumanization in healthcare that says, and I know this is just one way to organize it, but it makes some really good points. So it says the reason patients get dehumanized they identify causes. And the first three, moral disengagement, empathy reduction, and mechanization, they say are functional causes. So mechanization is where we think of people not as whole people, but as organ systems. It does facilitate clinical reasoning, especially when people are very sick. And so we break people apart to think about all the different components. It's a way of organizing our thinking. I think that's helpful. The idea of empathy reduction and moral disengagement helps people do their jobs, in very stressful, sad circumstances. I think there can be some function to that. There's also thought to be non-functional causes. De-individuation is like everybody's wearing the same hospital gown. During COVID, everybody had the same disease. They were face down, being ventilated. They certainly really hard to see all those people as individuals in that setting. But even just, when we use non-person first language and we refer to someone as, like a diabetic, it is de-individuating. It is also like agency reduction is sort of like people, when they're incapacitated, aren't able to think and necessarily make decisions. There's a thought that leads to dehumanization. So if we think about these causes, I think the neat thing about identifying these 6 causes is that there's like thought to be solutions that orient towards each of these causes. So where stigmatizing language falls in, I think, is in this moral disengagement and empathy reduction. I think if we refer to someone negatively and like the reader can then like disengage because they might think it's their fault or they're difficult or they're less worthy of my empathy because they behave in these ways, then I think that's where we want to reduce stigmatizing language to block that pathway. I think that, in testimonial, in the epistemic injustice book, Fricker describes the harm being agency reduction actually is not so much just like you can't make decisions, but like you as a knower is devalued. So there is a sense in which if you are not thought of as being able to tell your story, or you're thought of as being lying, like your agency is reduced. So I think that potentially is why that type of stigmatizing language can be so harmful. In addition to the fact that you just, don't believe what someone's saying and you can miss important things. But where I think medical records can make a big difference is in individuation and personification. So whereas we might think of people not as individuals, there are things we can put in records that will drive home the point that this is a person who does things, who has people who care about them. And instead of thinking about people as like breaking them into components or diseases or organs, we can think about them as whole people if we think about them as someone who's thinking and acting and feeling things, experiencing things. Think about them as a person. So when we did this study, the stigmatizing language study, although it didn't get as much attention in part because we didn't title the thing about positive language, there was a whole a bunch of themes we noticed about that we call positive broadly, and we hadn't really given this as much thought now as I think we have. But at the time, it was like we noticed that sometimes people got compliments, that they were charming, pleasant, and kind, delightful, like that appears in a good number of notes. People's behaviors would be described in the opposite of sort of like disapproval would be approval. So in some cases, like this first example, she has a physical and mental robustness that belies her age, is enjoyable to converse with on many subjects. That was kind of like one of the most unexpected and, kind of just popped in there in this note. But even like when somebody is engaged in behaviors that the clinician might think are unhealthy, like she struggled with quitting over the spring and summer, but as of this clinic visit has to quit tobacco for 1 week with a couple of exclamation points. So just the clinician is like enthusiastic about that, focusing on her strengths. So there was that. When people's unhealthy behaviors were described, sometimes there were reasons that accompanied that, so why is someone not doing the thing that you recommended? So sometimes that would appear. And then this, what we called at the time personalized, although we've sort of changed the way we're thinking about that, but these details about their lives. So, she's a songwriter and sings. She has a strong faith in God. She enjoys walking with her fiance and her dog named Scout. Kind of hard not to see that person as a person. So I think that there's a lot that can be done to improve care by changing the language in notes. So our most recent efforts have been to like look for that kind of language. We are using large language models that are HIPAA compliant, looking for individuating and personalizing, or I actually think it's, maybe personifying. Okay. But individuating being facts about someone and the personalizing being about like how somebody's feeling or thinking. So reminding the reader that this is a person who is feeling and experiencing and thinking about things. So we are looking for those lately. And then because we were invited to go to the EPIC conference, we learned about this possibility, which is that EPIC can be launched with something called About Me, which, as it turns out, Hopkins is going to turn on, except for they're not turning this on yet. They're turning on the About Me about the physician. So truly, like actually, like you can hover over a physician and it'll say like, I like to read books. Yeah, you got prompted to put that in? Yeah, you would have to put that in.
Okay.
Right. You, as a physician, you would have to put that in, you could say what you, right. But when I shared this, I said, no, that's not the about me I'm talking about. They were like, oh, okay. So I think there is a chance that we are going to build this out because it does come as part of the standard EPIC package that each institution can choose. So basically, if we do this, you get a prompt when you're signing in that basically says like your healthcare team wants to know something about you as a person, not just a patient. And then here's some examples, and then you can type something in. And then you can submit it, and that's how that would go. So this person said, I published historical fiction books in the last 2 months. Okay. So then basically what happens is, as the provider interface, is that you look at the record, and if you hover over this like about me logo thing, it pops up what the person said. So I think that's potentially really interesting. The presentation that I saw at the EPIC conference was they showed a bunch of different things that people had put in. So I think they've been names have been changed, et cetera, but these are the kinds of things people put in. And I do think like this is exactly kind of the type of individuating information and that we were like think that could improve care. It's just sort of a theory. And to end, I will say that this whole idea of humanizing records with this more positive stuff is the basis of the Making a Difference grant that we just got from the Greenwald Foundation, where we're going to try to see what kinds of humanizing language exists, and then can we do a survey to see whether it impacts decision-making of clinicians. So that is the end of that. Thank you so much.
Yeah, I was going to say, welcome for questions. We have one queued up, ready to go.
Thank you, Mary Catherine. That was a very interesting talk. I have a lot of questions, but I'll spare you for now. My first is a comment. I noticed you didn't include this unfortunate patient. It's always plagued me that when I see this in the notes, that's in a way, it's a positive. It reflects a positive bias, I think. So anyway, for what it's worth. But the deeper question for me is there a way to evaluate how the humanization of patients in the doctor-patient relationship will result in improvement in diagnosis and reducing diagnostic errors? One of the things we talk about in that space all the time is patients who get dismissed because they're difficult patients. They're more often than not women, at least disproportionately. And that leads them to being sent to psychologists and psychiatrists for their depression and anxiety instead of temporizing and expressing doubt or uncertainty and saying, we'll follow you over time and see maybe this will turn out to be lupus or something like that, where these diseases that are not readily diagnosed, endometriosis and others like that. So I'm interested in knowing how this humanization will impact better diagnosis and better care in general, not just because of a more trusting relationship, but specifically.
Yeah, because it impacts the clinicians, the subsequent clinicians that are making decisions and referring for tests and et cetera. Yeah, I do. I absolutely think, and I think that you gave the example of like somebody might be thought of as difficult and sent to psychiatry or blown off. Like I absolutely, if you look at medical error reports, a lot of them occur after someone is saying like, I was telling them that this happened, that this was a problem, or that I was experiencing this thing, and people didn't pay attention. So I think that the dismissal definitely causes that. But I think once people keep coming back, I think people with unexplained symptoms are often that clinicians will get frustrated and start to blame the patient, and anytime, and then the patient's frustrated, and so they might come across as frustrated, and then they get stigmatized in the record, and it just goes like in a cycle.
They didn't listen to me appears so often in malpractice cases as the reason why claims are filed.
Yeah,
we have a lot of examples here and in the world of law.
Hello, thank you for your talk. I wanted to ask questions about like the partnership with a bridge and specifically with the use of ambient AI tools. In my experience, talking to Black patients specifically, they actually get excited at the idea of having an AI scribe because they feel like they'd be listened to more since there's something else recording the conversation, which has like a humanizing effect in a way. So I'm curious to know how you're all working on that.
Yeah, I think that's a great point. I think the clinician always can edit the note after it's transcribed by the AI. So I suppose like, you know, there's always that influence at the end. But I think that, yes, I think that it's probably true that it might be more neutral in writing down what's said in the encounter from the patient's perspective. I think it's not going to write down really gratuitously negative things. It has started to put people's words in quotes. It's not doing it, I don't think, like, you know, to, it doesn't necessarily pick quotes to make people look bad, but because I think that there's such an interpretation of scare quotes, like someone wrote, people, people keep sending me because I do this work, like the quotes that this scribe is writing. One of them was just like really intimate. And I thought like, okay, that's a problem I hadn't even occurred to me. Like, what if that was a moment where like clinicians sometimes don't write things because we're trying to save people. Like, not everybody needs to see this thing that you said. So anyway, I don't know, but yeah, I think it could be positive, but we'd have to really keep monitoring it. Stephanie.
So I was just going to counter the bridge. All my notes, the scribe takes out my social history.
Yeah.
So I have conversations with patients about their life and humanize them.
Yes.
And it just puts in the medical history without any of the
Yes.
patient.
Thank you. Thank you. I forgot to say that, and that's super important. Mark, have you turned on, because I don't know if this is going to help it, but there's apparently like a more detailed version of the note that you can ask. Does that fix it? Do you know if that doesn't fix it? No. So that's why I originally reached out and started to try to work with a bridge, because I didn't really think that they were going to put in stigmatizing stuff, but all they really wanted was what's the list of words we shouldn't use and what are the alternatives so we can make sure we use the alternatives. So I did work with them on reducing the stigmatizing words, which is basically like a find and replace for the most part. But I kept saying to them, like, what you really want to do is you want to humanize people. Like, this is the most important thing I think you can do because it affects everybody. Like you saw, stigmatizing words appear in 5.5% of notes. This humanizing could affect everybody if you could do it well. And so, yes, I think AI in that way is reducing humanizing sentiments. But it has the potential not just to refer to what you're talking to, like to include the things that you would want to include when you're talking to people about their social history and their whole life, but it has the potential to also do other things that might be harder for clinicians to do, like use someone's name every time you refer to them instead of calling them patient. Maybe you don't do that, but a lot of people do that, right? So you could just use someone's name. It could report the history instead of reporting it by patient reports that this happened or patient states that this happened. It could say patient had began to experience this. Like it could do these minor shifts that would be, I think, maybe important.
We're going to jump the queue just to finish up on this point, and then we'll.
Just a dehumanizing tip for Mark. In infectious disease, we've had a lot of luck getting it to record that information by saying in the conversation that we're taking an exposure history and want to make a note of important exposures.
All right, so thank you for the talk. I'm a medical student, so I think something that I wanted to ask is the sort of dichotomy in on one hand, trying to be as accurate as possible when we're learning how to write notes. And I think some of that maybe, for example, like quoting patients in ways that might not make sense. I feel like could be for maybe some individuals, like trainees like myself, as an effort to like accurately convey this is what the patient said, but could be misconstrued as, is there a possible insinuation here? On the other hand, I've also been told, for example, even positive portrayals of patients, like this patient is a pleasant individual to work with. I've actually been discouraged to use that kind of language because that's not the experience of every provider who might interact with the patient or have a certain expectation when they come into the room with the patient.
Yeah.
So I'm interested to know, like, how do we balance, on one hand, possibly a neutral description of what happened versus possibly introducing bias in ways that could be helpful or harmful?
Right. Yeah. I mean, I think, okay, so the first, the quotes and then the pleasant, because pleasant is for some reason the most common word I think that we have. But for quotes, first I want to say, I think there are times really where quotes are helpful. If you can't reinterpret what someone said, in a way that, like, you don't want to reinterpret it because it was unusual enough and it didn't have a correlate that, there's times where it does actually promote accuracy, and not using them reduces accuracy. So I think using them in those cases makes sense. And it is also true that it's an illusion of objectivity with quotes because, people talk for 30 minutes and you've chosen 5 words to put in quotes. You picked which 5 words you wanted. So it's not really actually that much more accurate, except under certain pretty rare circumstances. So yeah, so that's about quotes. I think there was something else I want to say, but it doesn't matter. And then about pleasant, you're right. I don't think I mean, I'm not going to go and say that we should start calling first of all, if you call everyone pleasant, doesn't matter. And if you only call some people pleasant, then obviously there's going to be inequities in who you call pleasant. So, I mean, I'm not going on record to say that I think it's a good idea to use a word like pleasant. I will say that the only time that I will pull it out and use it is if I'm worried the person is going to get stigmatized by someone else. And so I might throw it in a note just to try to counteract the stigma that someone might experience. But I don't know that that's really right. So, thanks.
Thank you so much for the talk. It was really lovely. I just wanted to offer the observation that, one thing that stood out to me is the mileage that you can get out of like curiosity about patients' reasons. And it just seemed to me that there were a number of examples where there's a huge transformation between saying something like Mrs. So-and-so just hasn't checked her blood sugar and Mrs. So-and-so has like lost her blood sugar monitor, or there are these circumstances in the background and she's actually acting for, rational reasons once you understand the picture. And it just seems to me like that curiosity about reasons and causes like that can sort of transform somebody from someone who's like not doing what they're supposed to do to somebody who is an agent given what's going on with them.
Yeah, thanks. And I think that I thought that too. And I think that in the examples I showed, it does do that. I saw an example then that said, she's not taking her insulin because she doesn't think she needs it. And I was like, oh, that wasn't really what I meant. Like, I don't think but that probably is why the person wasn't taking their insulin. So I guess, I mean, it's not going to always fix it, but I do think you're right. Like you can get a lot of mileage if you really try to understand where someone's coming from. There might be also a better way to phrase, she doesn't think she needs it, but you'd have to do like a lot of work maybe to get to that. Yeah.
So I was wondering how, like, the increased focus on patient safety and staff safety on the medical units sort of interacts with this, because I know that there's been greater encouragement on the medical units of staff to document in more detail events as they occur. So if a patient, punches a nurse, it needs to go in the medical record. And the details surrounding it so that if it's triggered next time, there's more information. And we're sort of being told to give more information regarding security situations and patients that are high security risks, than less information.
Yeah, right. I agree. Somebody punches a nurse or anyone, I think, you're gonna probably document that. There's also a whole procedure by which you can, put a behavioral alert in someone's chart, although there has been shown to be racial bias in those, but I get that there can be safety reasons and that we need to protect staff. And that is why I think, yes, it can get, some of that when someone's really dangerous can and should get documented. I think that we probably overestimate how dangerous people are when they're angry. And so if somebody's, pacing, or, he ripped off his EKGs, it's a little dramatic, right? Like his EKG leads, pacing around the room. I mean, he's upset. I get, maybe if you feel threatened, I mean, you just try to remember, like, it is going to stigmatize them if it's in the notes. So like, is this our perception, or are they really dangerous? But if they're really dangerous, I think there's a reason it's justifiable to put in the note.
Moderators prerogative, because they have the mic. Why do you think open notes didn't change this pattern?
Well, I don't know that we have enough data really to know what's happening like after the 21st Century Cures Act. Like the open notes experiment, I well, first of all, I also think the studies that have shown it doesn't change are not like looking specifically for like some of these descriptions. They're looking at other stuff. So it could be that some of this description will come out. I still think we largely write as if somebody is not going to read it, and we don't lie. So even if they read it, like they did, let's say they did stand up, rip off their EKG leads and pace around the unit. I mean, we're like, well, they did it. So, I mean, I think that there's just this sense of like, yeah, you can still write these things because they might be like true. And even if they're going to cause harm, you're sort of protected.
So I guess, would there be any reason to think that the people that you're writing more stigmatizing notes about are less likely to read the notes?
Yeah.
Or do you think that's going on in the background? I mean, like while you're talking, I'm sitting here being like, what did my note look like last week? Clearly I generated. What did my daughter's note look like? They opened with Gabby's an adorable 3-year-old. I was like, well, of course she is. But
Yeah.
adorable is great for parents.
Yeah. I think that, yes, I think probably we're like less likely to think someone's going to read the note maybe. But yeah.
This isn't a completely thought out thing, but there is still quite obviously a tremendous amount of implicit bias in how documentation happens. And so when I have attempted to suggest a word change, I state concern about how something is documented. First of all, I'm a social worker and I'm glad to see that so many people in our department are present, but medical providers not uncommonly will dismiss concerns raised by non-MDs.
Mm-hmm.
The other thing that I think is interesting with the open notes issue is that there's not been as much training for our staff as it has been ongoing. People know that it exists, but they don't necessarily know what that means, and that it's access to the chart through my chart and how many people are actually enrolled and I do child protection work. And notice the number of notes that get blocked. And typically it's because there has been a hard conversation. I'm like, okay, so you're blocking the note about the parent's response to your communication to them, but the parent is the proxy, and they were present for the conversation that you are now blocking the note about, right? Like, I think that some of these relationship aspects still weigh very, very heavily on not just what's documented, but what we think somebody should have access to.
Yeah. Yeah, thanks, Phil. That's a great comment. I think you're right.
Clearly a sign of interest in this topic, and I've let the questions go over 1 o'clock. So thank you, and please join me in thanking Dr. Beach.
Oh, but I found.